TopMedTalk.
All right, well, it's Anesthesiology 2022. TopMedTalk is here in the exhibit hall at booth 2245. It has been a full day of amazing conversations, presentations here at the ASA, the American Society of Anesthesiologists General Meeting. I'm Desiree Chappell. I am your host today, and I'm joined by my co-host, Professor Monty Mythen.
Great to be here, Desiree. We just rushed back from a great lunchtime session that we were on the stage for with Professor Mike Scott.
Yes, and we're actually going to be catching up with Mike live.topmedtalk.com. So if you're listening to this right now and didn't know, we are live streaming our entire event this weekend. Every day we have brought all of our conversations out there to the world. Monty, that's live.topmedtalk.com. We have a couple other places, though, that we've had previous conversations with guests, and all the conversations we had yesterday and the ones we're having today are going out on our other sites.
live.edpom.org.
Yes.
But if you'll be, whichever route you go in, we'll guide you towards the listen or watch on demand content. If you just keep a track on the emails that follow up from going into live.topmedtalk.com.
Yeah, please be sure to share that with friends. And all of the conversations also are on your favorite podcatcher. So
it's all free.
And it's all free, yes. And that really cannot be accomplished. I mean, our mission to keep free medical education for the world is not possible without the generous support of our sponsors.
American Society of Anesthesiologists in particular for this meeting.
Yeah.
We're in partnership with them, and they've given us this wonderful space in the trade exhibition. And then we've got our platinum sponsors, Edwards and Medtronic, and a long list of other great sponsors, which we'll get to name check as we go along.
Yeah, absolutely. So thank you again for all of that. Keeping free medical education, keeping it free for the world. So, Monty, wonderful guests so far. These chats never disappoint. We have all different types, all different conversations. One of my favorite parts about TopMedTalk and the fact we keep coming back to anesthesiology meetings, a lot of the same meetings, so we get to catch up with friends from the past. So our next guest is no different. We have Dr. Bernd Saugel. Bernd, tell us just a little bit more about yourself.
Yeah, my name is Bernd Saugel. I'm a professor of anesthesiology and the vice chair of the Department of Anesthesiology at the University Medical Center in Hamburg in Germany. And my research focus is on perioperative hemodynamic optimization and specifically blood pressure monitoring and optimization.
Fantastic. Well, thank you so much for sitting down with us again. Last time we chatted, we were at ESA, the European Society of Anesthesiologists.
That is correct, yeah.
Yeah, that seemed like yesterday, but so long ago.
and if you want to catch up on that, put Bernd's name into our podcast site and you'll be able to get previous conversations. But we'll go over some of the stuff we talked about then again, I'm guessing.
Yeah, I was going to say we definitely want to follow up there. So Bernd, just before we kind of get into the major details of the DETECT study, which is what we're going to talk about today, let's just dive a little bit more into your areas of interest and some of the work that in general that you've been doing.
Yeah, well, the last couple of years we were very involved in research around perioperative hypotension. And next to that, we are very interested in how to optimize not only blood pressure, but also other hemodynamic variables, especially cardiac output, of course. So we not only focus on optimizing perfusion pressure and blood pressure, but we also focus on optimizing cardiac output. We are, doing observational research. We are doing interventional trials, and we will today discuss a trial on blood pressure monitoring. I guess the last time we were discussing a large trial that we are about to start where we individualize blood pressure targets. That is, going well. A lot of administrative work at the moment, getting all the centers on board, getting all the contracting done. But we will recruit the first patient in the next couple of weeks.
Can we just, I remember the conversation well, but for the audience who may not have heard the last conversation, because it's a very challenging, some people thought impossible to do trial. So tell us what you were trying to deliver.
Yeah, we are doing a 1,200 patient trial testing the hypothesis that individualizing blood pressure intraoperatively improves postoperative outcomes compared to routine blood pressure management. So we will do an overnight blood pressure monitoring the days before surgery. So we will measure blood pressure during the nighttime when
at home?
At home or in the hospital.
Okay.
That is Both is allowed, so we will record blood pressure like every 30 minutes at the nighttime. Then we will take the nighttime mean arterial pressure as the intraoperative target.
The nighttime one was the key component of it.
Absolutely.
Tell us a bit more about, because I remember you talking about dippers and non-dippers.
Yeah.
I've been a bit obsessed with that since, because
Very good.
My blood pressure's up a little bit, and I think, well,
Am I going to
So
be a dipper?
you should do a 24-hour measurement
I've done
and check whether you are a dipper. No, this is an important cardiovascular measure. It is basically if you look at blood pressure over 24 hours, you have a daytime and you have a nighttime, and during nighttime, during physiologic sleep, your blood pressure should drop substantially by at least 10 or 15%. And this is something that is a physiologic good sign. It is especially problematic if you are chronically hypertensive and you don't dip at night. So non-dipping is a known risk factor for cardiovascular complications. And we think that the nighttime mean arterial pressure is a reasonable target when we try to individualize our blood pressure target, because, of course, physiologic sleep is not the same as general anesthesia, but still people usually don't wake up in the morning with acute kidney injury, so the individual lower intervention threshold may be relatively well reflected by mean nighttime pressure.
And if you want to listen to the fuller details of that from the previous podcast, that was thought to be undeliverable, but you managed it.
Yeah, we've done those measurements in, almost 1,000 patients now in different pilot trials, and it's first of all, it is manageable from at our end, and patients also
don't report like loss of sleep or anything like that.
No, absolutely not. Well, it's an established way to assess blood pressure, and it's obviously the gold standard in cardiology if you want to diagnose chronic hypertension.
Right. I mean, you lie there initially thinking it's going to keep you awake, and then you fall asleep, and it doesn't wake you up.
Yeah, and I've done it myself, and everybody in our group is doing it from time to time, just that we know what we do to our patients, but it's not a problem, and patients really appreciate it, because they understand the concept, they understand that we are really looking at their individual physiology, and they totally understand that it's necessary to measure all night, and we have hardly any people dropping out because they just stop the measurement.
And then that's going to be as opposed to using a map of 65 millimeters of mercury or a systolic of whatever you choose, 100.
Yeah, we will choose mean arterial pressure.
Yeah, okay.
So
and then a diversion from or fall from baseline.
Yes, they are. Otherwise, so we in all the pilot trials and studies we did, we see that there is a substantial difference between what most, especially older people, have during the nighttime and 65. Otherwise, it wouldn't make any sense to compare those two targets in the trial. But we are quite confident that we will have a substantial difference between in the blood pressure target between the groups, and our routine management group will, in those patients, we will target or we will maintain blood pressure above 65 mean arterial pressure, and in the individualized group, we will maintain mean arterial pressure above the mean nighttime mean arterial pressure.
Just above it, so not a percentage above, like
to maintain it above, just above it, and it's there is no specific treatment algorithm, so it's in this aspect, it's a relatively pragmatic trial. But I need to acknowledge, of course, that the baseline measurement is something that is labor-intensive, but absolutely manageable in clinical practice.
Yeah, interesting. Any other questions?
No, I think we should go on to the new paper.
I think so. So new paper coming out?
Being under review at the moment.
Okay.
And being kind of a follow-up idea of the AWAKE trial that we published a couple of weeks ago in the British Journal of Anesthesia. So in that trial, we randomized patients to an unblinded intra-arterial monitoring with an arterial catheter during the induction of anesthesia, or to blinded intra-arterial measurements, so basically measurements with an upper arm cuff, to test the hypothesis whether continuous intra-arterial blood pressure monitoring reduces the amount of hypotension compared to intermittent measurements during the induction of anesthesia. And in that paper, we showed that you substantially reduce the amount of hypotension when you measure blood pressure continuously during induction.
So A-line in before induction. Now, if you're a cardiothoracic anesthesiologist, that's every day of the
normal
week.
Practice.
So you don't, and it's not very painful.
Absolutely.
It's local anesthetic. It's fine. I've had A-lines myself.
Yeah.
And one often ends up wondering why that hasn't crept into all practice, because if you do cardiothoracics, it's just every day of the week.
Absolutely.
So
it's the same
fuss?
here, but there's some relucance among us anesthesiologists to do it in non-cardiac surgery patients, and I don't understand why. And this is so the conclusion of that paper, because we substantially reduced the amount of hypertension with an arterial catheter inserted before induction compared to only after induction. We concluded that if you decide that there's an indication for an arterial catheter, that you then should insert it before induction of general anesthesia.
And Desiree, I'm guessing it's around the world, the non-cardiac bit is fairly common.
Yeah.
In other words, much more common practice in non-cardiac would be to put the patient off to sleep.
That's what I was just going to ask.
Yeah, and then
we'll
wait for the surge in blood pressure that happens when you intubate. We shouldn't be sorry, folks, that we aren't in our game, and use that surge in blood pressure to mean that's a great time to put the A-line in, because there's a nice pulse then.
Until there's the dip from induction if you haven't gotten it in soon enough. But yes.
So we're recognizing in that it's a roller coaster.
It is, absolutely.
Normally. And why wouldn't we keep it,
in the beginning,
steady? So what did you find? I'm guessing. Well,
and in induction of anesthesia is kind of a scheduled event. Event. When the patient will be hypotensive, and therefore it's kind of strange to wait with putting the optimal monitoring device in just after induction. So, this was the AWAKE trial. But of course, after the AWAKE trial, people keep asking me, okay, what do I do in patients who are not monitored with an arterial catheter? And we all know that most of the patients having surgery don't have an arterial catheter. And therefore we came up with the idea for the DETECT trial. And the DETECT trial tests the hypothesis that continuous blood pressure monitoring during the induction of anesthesia and during surgery reduces hypertension compared to intermittent monitoring with an oscillometric upper arm cuff. And for continuous monitoring in this study, we used finger sensor device and compared it to the upper arm cuff.
Now, I know just anecdotally that many people who've been exposed to the opportunity to do the finger cuff blood pressure measurements have automatically chosen to take that into, for example, their emergency theatres, where they say, this is a great population to put this on before induction of anaesthesia, because these patients are often very unstable, overtly very unstable, possibly even to the point of cardiac arrest post-induction of anaesthesia. So it's following that through to look at it systematically. It's doing it you did it in an RCT, basically.
Yes, it is it's a 242 patient randomized control trial, and we randomized patients just before the induction of anesthesia to unblinded continuous finger cuff monitoring, or to blinded continuous finger cuff monitoring. And blinded finger cuff monitoring basically then meant, of course, that anesthesiologists were looking at intermittent upper arm cuff measurements. We tested two hierarchical primary endpoints. So the first primary endpoint was the area under a blood pressure threshold of 65 during the induction. I may explain later why we choose the area there. And then during surgery, we looked at the time-weighted average mean arterial pressure, and this was a second primary endpoint. So the first part of the trial looked at the induction period, and we defined this as the first 15 minutes after the first anesthetic drug went in. And then in the second part of the trial, we just kept the finger cuff on the patient's finger, and we followed the patients through the complete surgery.
So if I'm right, with the hierarchical approach, you've set your stall out. We'll talk about why you chose them in a second. To say that if you set your alpha, your significance level at 0.05, if you hit the first one, you can look at the second one without adjusting. Is that correct? So you can go down the hierarchy if you state it in advance.
That is correct. It's we could have done we could have adjusted for two endpoints, just as you explained now.
Pushes out.
Yeah. But the rationale behind it was that I thought to myself, okay, the post-induction period is the period where this concept should work, because the severity of hypotension, the drop in blood pressure, is more pronounced just after induction. And if it doesn't make a difference there, then it's very unlikely that it makes a difference during surgery. So we ended up with this approach. I would have been comfortable that we could have done it also with two co-primary endpoints in adjusting the p-value.
I'm guessing you hit them both, and you would have got them if you'd adjusted the p.
Yeah.
Okay. That's so they were ding.
I'm trying to follow along on this.
Yeah, we may discuss a little bit why we chose those endpoints.
Yeah.
You know, it's very hard to quantify hypotension, and it's there are two quite unintuitive measures that are very important. So this is the area under blood pressure threshold. So this looks at the severity of hypotension and the duration of hypotension. And if you want to normalize that for the monitoring time, you divide it by the monitoring time, and then the area under the threshold becomes a time-weighted average mean arterial pressure.
So let's imagine we got a line at 65 and the blood pressure's running along above it. That has no impact. Once it goes below 65, if we now imagine in our mind's eye a graph of the sort of curve under the line, if you coloured that in and measured the area of it, that's the area under the threshold curve.
Yeah.
So if it's a big area under the curve, there's a lot of hypotension happening.
Yeah.
And then you've got to adjust for time. So you adjust it by a time interval, and it comes up with this time-weighted average number that's very hard to get your head around. But
if you think about
the bigger the better.
Perspective of an organ that wants to be perfused, then of course the area under the threshold is the meaningful measure, because of course, for example, for the kidney, it's important how long and how severe hypotension is. But if you want to compare two different groups, it is kind of unfair if in one group, for example, the duration of surgery is substantially shorter, then those patients would have less time to accrue hypotension, and therefore, if you compare two groups in a randomized trial, it's better to look at the time-weighted average.
So we see it occurring a lot now. TWA, and then it's given in strange units to many of us. What are the units it's presented in?
It's millimeters of mercury. Everything else equals out.
Mixed out.
Yeah.
And a sort of good bad number. Good numbers are coming in at about sort of 0.0 something if you're doing very well.
True. Yeah.
And bad numbers are coming in at sort of 0.2, 3,
4.
That sort of thing.
Yeah,
So we're not used to it as a measure, because it doesn't. 0.4 of a millimeter of mercury doesn't sound like such a bad thing, does it?
Absolutely. The absolute numbers are relatively low, and it's much more intuitive from a clinical perspective to look at the incidence of hypotension, but this is then just a single value, or to look at the duration of hypotension, but, well, the physiologically meaningful, harmful burdens really is the area under the curve, and then if you want to compare it, you need to normalize it for the duration.
I've been working quite. Sorry, I'm doing a lot of talking, Desiree.
No,
I've been working quite hard. I've been working quite hard how to get a reference point in my head, and where I've got to is sort of like 0.1 and below.
Zero.
Is zero. Sorry. 0.1 and below. So think of it almost like a p-value, a significance value.
Okay.
As it goes lower to now you've got a naught after the dot. That's getting into the group where you're avoiding a lot of hypotension.
Okay.
Whereas once you're into single figure, 0.1, 0.2, 0.3, 0.4,
you're having
there's
more.
There's a lot of it going on.
Okay.
So that's kind of, I think of it now, I try and reference it to a bit like a significance value.
Okay.
It's not the same, but to get it in my head, I say 0.05. Oh, that's quite impressive. Whereas 0.4, you say, ooh,
not good.
Is that about right?
That is a good way to memorize it. Yeah, I always have in mind the time-weighted average that were observed in the interventions and the control groups in certain trials, and I know that, for example, 0.4 is relatively much. It's a lot of hypotension. 0.1 is what you would expect if you take care of blood pressure, and everything below 0.1 is very little. So.
Because you'll have that in your data that you presented. One of the figures will be the TWA. But anyway, we might be boring some people with this conversation.
Well, no, I'm following. Not as a trialist myself. It is a little bit more complicated to understand, but let's keep rolling through.
Getting back to the clinical.
Yeah.
So tell us the result.
Yeah, I was like, I'm dying here.
Yeah, I tell you the result. It's so during induction, we were looking at the area under the curve, and we did that because in all of the patients we only looked at the first 15 minutes. So therefore it wouldn't make sense to normalize for the duration if it's the same length of observation.
It's all 15 minutes.
It's all
so you can
15
do just
minutes.
the area under the curve.
Yeah. So we looked at the area under the curve, and without giving you the exact numbers, but we in patients randomized to continuous finger cuff monitoring, the amount of hypotension, the area under the curve was substantially lower than in patients randomized to intermittent monitoring. And the same is true for the second primary endpoint for the time-weighted average mean arterial pressure below 65 during surgery. Again, there was a substantial reduction in hypotension when you measure blood pressure continuously.
And that's what we would intuitively think. But just to be clear, it was by making the number available change the practice. You didn't tell them to do anything about the number you made available. Is that right?
That is true, but we need to consider that this was a monocentric trial in my institution, and I'm running around there for a couple of years telling everybody that hypotension is a bad thing. So I would assume that the effect size is the same in other institutions, but the baseline may be different. But there was no specific treatment algorithm. What we see that in patients randomized to continuous monitoring, patients received a little bit more vasopressors, so the availability of continuous blood pressure monitoring, naturally during induction and during surgery, resulted in giving more vasopressors. The amount of fluids was comparable, and it's that was the main difference in the intervention.
So now I'm guessing the next conversation is going to be, do we have to prove that out to show that it makes a difference to outcome? Mm-hmm. Or, as we think our objective is to avoid hypotension during induction of anesthesia, enough already, if you see. What do you think, Desiree? Do you think, it's always, some people are going to demand the outcome, and they're going to say, well, we're just doing our job better, aren't we?
I know. Well, we had a lot of conversation with Rick Dutton about this, and it's like, where do we go? Do we wait for the outcomes, or do we just start, treating?
Well, he was suggesting fix and then see if the outcomes come.
Fix and then see if the outcomes come. Yeah, and I'm almost with him. I mean, I was always convinced, no, we'd have to show the outcomes. We have to look at that first. But
it's a lot
now
of waiting.
It is a lot of waiting, and more getting into the trial that we're working on, or the study that we're working on. I'm really kind of being convinced, like, let's just go ahead and get on with it and see if we can actually learn from our experiencing changing practice and all those things that take a lot of time too. But let's start on that and then look at outcomes.
Or a combination of the two. Bernd could do a wonderful RCT, very carefully controlled, because there's some mechanisms that need understanding. Yeah. And you all could do a real-world evidence evaluation, because we're probably going to want to know that, you might give phenylephrine and make things worse or better. You might, in induction of anesthesia, might be when the little heart attacks are happening. Maybe that would go away. So maybe both at once. Yeah, go at it.
Could do it.
I'll stand over here and make clever suggestions. You will get on and do the work.
Thanks,
what do you think, Bernd? What are you going to do?
Well, as a researcher, I of course would love to do a large randomized controlled trial on that. I need to acknowledge, though, that when we talk about this patient population, patients who are monitored with a finger cuff, those are not particularly high-risk patients, so the incidence of postoperative complications is then lower than when looking at high-risk populations. And considering then the association of hypotension and postoperative outcomes, and that postoperative outcomes are still there are multiple factors contributing to postoperative outcome. We would really need a lot of patients.
So what about, even though it's probably not possibly going to be economically viable as a trial, if you chose the high-risk patients that are going to get an A-line and you bridge them with the finger cuff, so you could do the mechanistic bit and say, I'm going to randomize to a high-risk group that's getting an A-line non-cardiac to finger cuff, no finger cuff, and then they both get A-lines. That might be a quicker route.
Absolutely. Kind of, contradicts what we did in the Awake trial when we now concluded and we now recommend to put in the A-line before anesthetic induction.
Tricky, but
from a methodological perspective, that's a brilliant idea. Yeah.
Because I don't think you'd find problems. Maybe your centre's changed, but I don't think you'd find trouble, Desiree, finding people who want to put the alien line in afterwards.
That's
current standard
practice.
of care. I don't think it's even equipoise. I think there's anyway.
Yeah.
Thank you.
We should start working on the trial protocol. It's a very good idea.
I'll let you run with that one, Liv. Let me know.
Or anyone else there who's listening, please get on with
there
it.
you go. No, I mean, I think it is interesting. I think we do need to know both, high risk and the low to moderate risk patients, because we are seeing a lot of hypotension in our low risk patients as well. I mean, actually more hypotension in our low risk than our higher risk patients in the study that we've been working on. And so I'm just kind of trying to figure out, like, we still need that information.
I'm a bit of a downer on the overuse of vasopressors, but in the window of induction of anesthesia, for that transient period there, it makes complete sense to me that you'd mitigate the hypotension with a vasopressor. I'd hope that one would then try turning it down and off to see if you can restabilize without the dose you chose at the beginning.
I think we can agree that we should treat the root cause of hypotension. We should treat hypotension causally, and we've done an observational study a couple of years ago where we looked at the induction period, and vasodilation is the mechanism behind hypotension after the induction of general anesthesia. So I think after induction, it is reasonable to give a vasopressor. We use norepinephrine in our institution.
I was going to ask you that one. There's at least a pharmacological argument that that's a better choice than a pure alpha.
Yeah.
You've got a bit of beta in there as well. But, you're giving it peripherally now, as many places are, or are you still giving it centrally? Or
we give it peripherally. It's without any problem.
Yeah, there's a few publications now reassuring people that there's no problems. Yeah. We've seen a few recently. There's no problems giving it peripherally.
Yeah, the problem is trying to get pharmacy to mix that for you. That's your problem. but making a case for it now with the literature coming out, I think it's important. Well, Bernd, what's next for you? I know you're doing the next trial coming up on the blood pressure. Anything else that you're working on?
We are about to start another trial on cardiac output guided management, again with an individualized approach, which for cardiac output is even more complicated than for blood pressure, because blood pressure regulation is something that is relatively slow, and as you know, cardiac output regulation is very complex, and cardiac output, the main determinant is metabolic needs. This is something that is very hard to predict at baseline, but still there are substantial interpatient differences in variability in cardiac output, and we've done a pilot trial on individualized cardiac output management that was very positive, that was published in the BGA 2 years ago.
What method did you choose?
We had a finger cuff system to measure baseline cardiac output with the patient resting the day before surgery. And we used that as an initial intraoperative target, and in close to 200 patients, so a small pilot trial. This individualized cardiac output guided management substantially reduced the composite of complications, and we will now start doing a large multi-center international trial testing this hypothesis that individualizing cardiac output during surgery improves outcomes. But this is from a physiologic perspective with regards to cardiovascular dynamics. It's much more complicated than blood pressure.
And Optimize 2 is coming, which is not individualized. So to remind ourselves, Optimize 2, about 2,500 patient randomized controlled trial, major intra-abdominal surgery, infection is the primary outcome. The algorithm is stroke volume optimization, followed by a fixed dose of a vasoactive agent that is more of an inotrope than a vasopressor. So it's kind of not goal-directed in one way, because it's not individualized and it's not adaptive, but it's very pragmatic and we'll get an important answer from that
Absolutely,
question.
that will be the largest and most robust trial that we have thus far, and it's kind of, it's an individual maximization of stroke volume, I would say, because you in every single patient you kind of maximize stroke volume based on the individual physiology. So you push the patient to the flat part of the Frank-Starling curve, which is somehow individualized, but it's still maximization. And our approach is that we individualize considering the baseline value, and we will see. This is a second large trial, also more than 1,000 patient trials, or these 2 trials will keep me busy for the next 1 or 2 years, I guess.
So back here in 5 years' time, as we keep reminding ourselves, we'll be confused at a much higher level.
Yeah. Was much more data, but still confused. Yeah.
No, you're answering some questions for you. You're doing great work.
Yeah.
You and your colleagues are doing really great work. It's hard stuff to do, so thank you.
Yeah.
Thank you very much.
Well, Bernd, thank you so much for sitting down and joining us in this follow-up conversation from the ESA. We really do appreciate it and look forward to hearing more about your work in the future. And thank you for listening to TopMedTalk. We are here at Anesthesiology 2022, and wonderful conversations. If you've missed any of those, I think they're starting to come out now on our site, any podcatcher, TopMedTalk.com. Be sure, if you like what you're hearing, share with friends at live.topmedtalk.com.
All free?
It is all free. Yes, absolutely. See you soon.
Take care. TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.